they can play a significant role. And these peptides are being produced by many different species, including plants. Now, having said there are many of them, actually in humans, there are very few. There are different groups. The defenses is one of them, but one of the most powerful one, most common one, is the human cathelicidine, which is called LL37 because of its structure. And we worked with a team in Germany to really develop synthetic peptides, which are based on the structure of both LL37 and the limulus anti-LPS factor. And these are two peptides here. These are the structures, peptide 2.5 and peptide 19,4-LF, both of which bind to endotoxin, but also bind to other PAMs and other DAMs, including heparin sulfate, for example, and HMGB1. A number of years ago, in 2016, so these are relatively old data, we reported that these antimicrobial peptides reduce the organ dysfunction in sepsis by neutralizing endotoxin and other factors. And I already mentioned heparin sulfate and HMGB1. Based on this sort of finding that they also bind to other factors, we wondered whether we can utilize them in other conditions. And the first other conditions which we looked at was a high-fat diet, because high-fat diet leads to what is called metabolic endotoxemia, which is the translocation of endotoxin from the gut to the systemic circulation, and this causes a degree of systemic inflammation. In the first study, we measured the human antimicrobial peptide LL37 in healthy subjects, and these are the levels which are relatively low in healthy volunteers, and they are significantly increased in patients with type 2 diabetes. We were then wondering whether this increase in the antimicrobial peptide is a defensive mechanism in response to endotoxemia. And in one study, we looked at this, and we caused diabetes, and I have only one slide. This was a 12-week model of high-fat diet. You can see that this high-fat diet causes, this is a normal liver, this high-fat diet here in the middle causes a significant deposition of fat in the liver, and when we treated these animals with the antimicrobial peptide, this fat deposition was stopped. And these are the histological images. This is the sham animal, a normal animal here, normal mouse. And this is the fat deposition in the liver, stained in red, and this is after treatment. And this is here in summary. There's no fat in the liver in a normal animal. That's dramatically increased. This goes together with an altered glucose tolerance test with an increase in baseline glucose. And this is pretty much abolished by this antimicrobial peptide. And this also goes together with a reduction in liver injury. So we reported then in 2021 that a synthetic peptide designed to neutralize endotoxin attenuates meta-inflammation and diet-induced metabolic alterations in mice. And this was a big collaboration between us and colleagues in Germany and in Italy. So we were then wondering, what about trauma? Because these peptides also bind to factors which are released in trauma, including HMGB1 and heparin sulfate. They're all released in trauma. So we designed a study in hemorrhagic shock, and this is the model. After surgery, which is used to instrument the animals, we take blood from the carotid artery here in the yellow period and keep the blood pressure down to 30 millimeters mercury for 90 minutes. This is to simulate a period of major blood loss. The animals get then resuscitated with shed blood and ringer's lactate, and then are maintained for 4 hours or so and receive one of these antimicrobial peptides in a low dose and in a high dose. The red arrows in the top panels in A is an increase in urea and creatinine. You can see this was significant. And the creatinine clearance is going down. So all three indicators show that the kidneys don't function properly anymore. And this is reversed, not fully restored, but the high dose of the peptide certainly has a quite dramatic effect. So creatinine is almost back to normal. Creatinine clearance comes almost back to normal. The same was true for lactate. Lactate is an indicator of tissue hypoxia. There was a significant increase in lactate, which was dose-dependently reduced by the peptide. So this peptide reduced renal dysfunction, liver injury, pancreatic injury, lung inflammation, systemic inflammation, blood pressure was recovered at the end of the experiment, and activation of NF-kappa B and was prevented, as was the formation of pro-inflammatory cytokines. And this is the publication reported in 2018 in Annals of Surgery. The lead author here is Noriaki Yamada. He was from Gifu University in Japan. He joined my team as a postdoc after Regina de Sodi was with us, and he is here very happy. He's normally very severe, very stern and very earnest, but he is very happy here that his paper was accepted. So where are we with these? I said I would not just talk about academic science, I would talk a little bit about drug development. Where are we in the drug development process? So the patents for these peptides were applied for and granted to our German colleagues, which we collaborate with. The preclinical data for a number of diseases have been collected as preclinical packages, and they are ready in a way to go to the MHRA when it comes to the efficacy. For toxicology, which is ongoing, one needs to generate a GMP formulation of the drug, and this is usually very expensive, and it was, but we have formulated the drug, but toxicology studies are now ongoing. Now, the next step would be the phase 1 human volunteer study, and these are usually rate limiting. You need to usually have big pharma coming in and finance these studies, or very significant grant funding to finance phase 1 and phase 2 clinical trials. So this is likely to be the rate limiting factor. Now, this is not just true for this project. This will be true for every single project you do in an academic lab. So the question then arises, how can we overcome this? And one way to overcome this is the repurposing of existing drugs, which was for the first time really successfully shown on a large scale in COVID. Because when COVID emerged, there was no chance to develop new drugs for COVID, apart from the vaccines, but it would have taken too long to develop specific new drugs. So we fell back to drugs which we already knew, including dexamethasone, remdesivir, and the IL-6 receptor antagonist, all of which had showed some beneficial effects because they were tried in patients with COVID and reduced morbidity and in some cases also mortality. I want to speak about two other repurposing strategies, both of which are now also being trialed in COVID, based to some degree on our own work, and I come back to this. One is the antimalarial drug artesunate, and one are the BTK inhibitors, and I will come back to those and explain what they are. So the repurposing of the antimalarial drug artesunate in patients with trauma and severe blood loss was done at our hospital, the Royal London Hospital. Artesunate has been used in more than 300 million people. It improves survival in severe malaria. It has an excellent safety profile in patients with multiple organ failure, because patients with malaria do have multiple organ failure. And there are nearly 300 clinical trials now listed on clinicaltrials.gov. The World Health Organization recommends artesunate as the drug of choice for complicated malaria, and the dose they recommend is 2.4 milligrams per kilogram. This discovery of artesunate and the groups of drugs, which are called the artemisinins, was awarded the Nobel Prize in Medicine and Physiology in 2015. And the Nobel Prize was given to Dr. Yao Yao Tu, who is here in the middle, who was the lead investigator of a large team of investigators at the Chinese Academy of Sciences. This is the first very large clinical trial in which 2,712 children here were treated with intravenous artesunate, and the other 2,712 were treated with a reference drug, quinine. And this study showed that artesunate reduced mortality much better than quinine. Now, this is a bit surprising. They're both quite powerful anti-malarial drugs. Why would one reduce mortality, the other one didn't? So there were only two explanations. One is differences in pharmacokinetics, because artesunate is an IV drug. You can get it in very quickly. It peaks very quickly. The other one was that artesunate would do other things which are not related to the antimalarial effects. We trialed artesunate in hemorrhagic shock, and this was by chance because, I guess I can come back to this in the discussion. if somebody wants to know, we trialed artesunate in a different area and then by chance tried this in hemorrhagic shock. Now, scientists don't like to talk about chance discoveries because it's nicer to have a theory or a plan. And so afterwards, after we made the discovery, we looked at the similarities between severe malaria and hemorrhagic shock. And because both have an element of ischemia reperfusion in them, there are some significant similarities, which are highlighted here in red. We used our same simple rat model to trial artesunate. So feeding to a blood for 90 minutes, and then for 4 hours resuscitation. The dose of artesunate was either 2.4 milligrams per kilogram, which is the same dose used in humans, or 4.8 milligrams per kilogram, which was a dose escalation of this study. As I've shown to you before, hemorrhage led to a significant decline in creatinine clearance and an increase in creatinine, indicating acute renal dysfunction. And this was attenuated by artesunate, although you can see that there was no real dose dependency in this effect. It also led to an increase in AST here and ALT, and this was attenuated by artesunate. So liver injury and renal dysfunction were reduced. We looked at a number of potential mechanisms of action. Analysis that artesunate causes the activation of the AKT survival pathway, which leads to phosphorylation of GSK3 beta, and therefore inhibition of inflammation, inhibition of NF-kappa B, and inhibition of the formation of TNF and IL-6 and INOS expression, and also resulted in eNOS phosphorylation. And this was true for the kidney, liver, and heart, so it was organ independent. Regina was the first author on this study. This was done while she was in London and published in 2017. So based on these preclinical studies, really led and driven by Regina and previously by Noriaki, we wanted to translate them to a clinical trial. Now, the first challenge which we encountered was the fact that artesunate, which is produced in China or in Vietnam, is a non-GMP drug. Now, this doesn't take anything away from the quality of this drug. It's a very good drug. But by law in Europe and in the US, one needs to have a GMP formulation of a drug to do a clinical trial. So at this point, we were stuck. I thought that money would be the biggest problem. The cost of the study would be the biggest problem, but this was not the case. It was the lack of a GMP drug. It took us a number of years and many, many telephone calls to find a potential company in Italy, which was then called Sigma Tau. The company is now called Alpha Wassermann. And they developed a GMP formulation of artesunate together with the US Army, and in fact, for the US Army. So we had a partnership between this company in Italy, then Sanofi Aventis, who developed the investigational medicinal product of artesunate as a non-GMP product, and then the US Army, who provided the phase 1 human safety data. This was a clinical trial, 105 patients, 35 were randomized to the low dose of artesunate, 35 to the high dose of artesunate, and 35 to placebo. We wanted to give the drug within 4 hours of injury, and we enrolled over two years. So the study was conducted between March and July 2019. A total of 90 patients were randomized to either artesunate or placebo. There were 10 exclusions, and leaving a total of 75, and 5 due to declined consent, leaving a total of 75 in the per protocol population. 27 of those were treated with placebo and 48 with artesunate. So we had a relatively decent power in the artesunate arm, but maybe a very weaker power in the placebo arm. There was an interim review in 2019 as part of the safety analysis, and they indicated to us that the trial should be terminated due to the potential increase in venous thromboembolic events in the artesunate treatment group. I can come back to this. So these are some of our headline data. So we said we wanted hemorrhagic shock. So the systolic blood pressure in the placebo group was 90, in the artesunate group was 84, so fairly similar. The base excess, which measures the degree of organ ischemia to some degree, was 4.7, minus 4.7 in the placebo group, but minus 9 in the artesunate arm, which indicates that this was almost significant. By chance, in the artesunate treated patients, the degree of hemorrhage, the degree of organ ischemia was significantly greater than in the placebo group. So this is very unfortunate, I think. Now, you would expect that greater ischemia leads to more organ failure. SOFA score means sequential organ failure assessment score. So this was organ failure at 48 hours after trauma. 4 was the placebo value, 5.5. So it was increased. So there was more, not significant, but there was more organ failure in the artesunate group. You'd expect that more organ failure leads to more prolonged organ failure, and this was not the case. 23% of the placebo patients had prolonged organ failure, and only 21% of the artesunate treated group. Acute lung injury was 75% of the patients in the control group had acute lung injury, only 64% in the artesunate group had acute lung injury. So that was quite a dramatic reduction. It could have been chance. Length of intensive care stay is quite an important parameter. So in the placebo group, the average intensive care stay was 11 days, while in the artesunate group, despite more multiple organ failure, the intensive care stay was reduced to 8 days. However, and this is the big caveat of the study, the number of thrombovascular events, which do happen in trauma hemorrhage because you have a lot of platelet activation, was 12% in the placebo group and nearly 50% in the artesunate group. And this was also nearly significant and would have surely been significant if we would have continued in the study. So in summary, there were no differences in the primary endpoint, 48-hour SOFA score between artesunate and placebo, or any of the secondary endpoints which were listed here at the bottom. The proportion of patients with serious adverse events that were thromboembolic were potentially higher in the artesunate arm than in the placebo. Now, if the increase in thrombosis and thrombovascular event is true caused by artesunate, then this may have implications both for malaria, but this was probably not looked at, but also for a potential translation of artesunate for COVID-19, because these studies are ongoing. And I have advised both the Wellcome Trust as well as the Bill and Melinda Gates Foundation, who are driving these clinical trials both in malaria and in COVID-19, of our study data, even when they were confidential and not published. So I mentioned artesunate, but at the same time I mentioned BTK inhibitor. What are these BTK inhibitors? So these are studies carried out by Caroline O'Riordan and Nikita Patel in my group. BTK stands for Bruton's tyrosine kinase. This was first identified in X-linked agammaglobulinemia in humans. BTK is a critical component of the B-cell antigen receptor signaling pathway, which is involved in the development of B cells in normal and malignant B cells. BTK is also involved, and this is important for our study, in TLR signaling pathways and regulates the activation of the inflammasome. So we were wondering whether inhibition of BTK with ibrutinib and acalabrutinib may attenuate the organ dysfunction caused by sepsis and/or trauma. And the first study was done in sepsis. The reason why we studied BTK is because they have been used. This is a repurposing strategy again. The first generation BTK inhibitor, ibrutinib, is used in mantle cell lymphoma and all of other these clinical conditions. The second generation BTK inhibitor is more specific. This is called acalabrutinib and is used in mantle cell lymphoma. Here you can see the number of kinases in red which are inhibited by these kinase inhibitors, and you can see that ibrutinib inhibits many, acalabrutinib inhibits a few, but still more than one. So this study was carried out in C57 black 6 mice, which were 10 weeks old, male. We caused a cecum ligation puncture sepsis, and then 1 hour later treated the animals with IV injections of ibrutinib and acalabrutinib. 6 hours later, we gave antibiotics and analgesics and repeated this at 18 hours. And 24 hours later, we looked at multiple organ dysfunction. First of all, we looked at BTK activation in the heart because we were particularly interested in the heart, and we found that sepsis leads to BTK activation in the heart, and this is abolished by both BTK inhibitors. Sepsis also led to a significant cardiac dysfunction. This is a reduction in ejection fraction here, which is the amount of blood pumped out of the heart with one contraction, sorry. And this cardiac dysfunction was restored by BTK inhibitors. Here it's shown that BTK interacts with the TLR4 domain at MYD88, MAL, IRAK1 in a number of different places. In a number of these different places. So we postulated that this inhibition of BTK may prevent the activation of NF-κB. And this was indeed true. So we looked at IKK phosphorylation, IKK alpha and beta phosphorylation, as you can see here. This went up in the heart in sepsis, and this was attenuated by the 2 BTK inhibitors. The same was true for many other indicators, including the translocation of P65 into the nucleus. This happened in sepsis and was abolished by the BTK inhibitors. BTK also interferes with the assembly of the inflammasome at the ASC level, and we looked at this. Here, sepsis leads to BTK and leads to assembly of the inflammasome, and this is attenuated by the 2 inhibitors of BTK, and the same results then in inhibition of the activation of caspase-1. Now, I said that many of these BTK inhibitors have off-target effects, and even acalabrutinib, which is quite specific, still inhibits 5 different kinases, some of which may well play a role in sepsis. So we wanted to do if you like, a knockout study. These animals are not knockout animals because they have a single point mutation in the BTK gene. So it's even better than a knockout because the BTK protein is still in place, but the protein is not functioning. And these are on a different background. We didn't do any shams because these animals were very expensive. So this is the normal sham range in these animals, in mice in general. So sepsis resulted in a decline in contractile function of the heart. And this was completely abolished in XIT mice, these mice with a mutation in the BTK gene. And I think pictures always are more impressive than histograms. So this is the contractile function in the wild-type mouse with sepsis, and this is the contractile function in the CLP mouse with sepsis. You can see that the heart is contracting much more significantly, and this is, I think, quite obvious to see. I always ask my students and postdocs, what do the animals look like? Because you can really tell from what they look like. This is, on the left-hand side is the wild-type mouse, and on the right-hand side is the XIT mouse. I think you will appreciate that these mice, both of which have sepsis, behave quite differently. The XIT mouse is happy to explore the environment and is overall very healthy and inquisitive, despite the fact that it has a sepsis challenge, while the wild-type mouse is quite ill. And these are the publications arising from this. The first one on the left shows the effects of the BTK inhibitors in sepsis, and the second one shows the XIT mice and the XIT mice knockout, if you like, study. We followed this, and this is, I think, my final data set with a trauma hemorrhage study with BTK inhibitors, because we knew that inflammasome activation and NF-κB plays a role in trauma. This again was led by Nikita Patel and was a collaboration with Regina's group in Florianopolis. I come back to this. And I only have 2 data slides. This is from the acute hemorrhagic shock model, which I already have shown to you. This was done in London, in my group. This was in the rat. We found that hemorrhage and resuscitation led to an increase in LDH and for tissue injury, an increase in ALT and AST for liver injury, an increase in urea and creatinine for renal dysfunction. We used two different BTK inhibitors, acalabrutinib and fenbrutinib, both of which you can see here in yellow and orange, attenuated the multiple organ failure. We then wanted, and this is often requested by reviewers, certainly reviewers of good journal, have longer resuscitation periods. And this is here for 24 hours. And this was done at Santa Catarina in Florianopolis by Regina and her colleagues. Even 24 hours after the insult, there is still a significant increase in LDH, and this was attenuated by acalabrutinib. There's an increase in liver injury, ALT, AST, and this is attenuated by acalabrutinib. The renal dysfunction has recovered to some degree at 24 hours. And this is Nikita being not so happy maybe about the study results, but happy about the fact that she can be in Florianopolis rather than sitting in rainy London. Now I come to the end of my talk. In summary, I have spoken to you about some of the emerging drug opportunities and challenges for drug discovery. I spoke about trauma, sepsis, and organ failure, and 2 or 3 slides on the metabolic syndrome. The biggest challenges, I think, to do this in an academic setting is the jump from a preclinical data set, which you can easily generate in an academic setting, to generating the GMP formulation of the drug and the toxicology data. That's the first big hurdle. And even if you can do this, because the limit here is usually money, then you have to move to a phase 1 clinical trial, and the limit here is much more money, because there's an exponential increase in cost when you move to a phase 1 clinical trial. This is why we have circumvented this route by repurposing of drugs which were already on the market. In the case of drugs which are already on the market, these data sets already exist, so you have to just collaborate with a pharmaceutical partner who has the relevant data sets. So we collaborated with artesunate, with Sigma Tau, who generated the GMP formulation, and then basically with the US Army and Sanofi, and really generated the clinical trials dossier in the package to do these clinical trials. So for us, this was possible with artesunate. In other studies, BTK inhibitors have now used in patients with COVID. So collaborators have been able to make use of our preclinical data, show the efficacy that we have generated to the local authorities, and based on these, carried out clinical trials in COVID. Clinical trials with artesunate in COVID are under discussions. I am obviously a little bit concerned, given that we found an increase in thrombovascular events in patients with trauma hemorrhage, but to the knowledge of all our colleagues at the Bill and Melinda Gates Foundation, these effects have not been seen in healthy volunteers. So they're pretty certain that even very large amounts of artesunate do not cause these effects in healthy volunteers. So I come to the end of my talk. Regina, I think, asked me to speak to 35 or 40 minutes or so. This were many of the people worked on some of the early studies here. The top art clinical trial teams is shown here. This was involved in the clinical trial. And the later data were generated by Caroline O'Riordan here on the left in the blue dress, and then Nikita and Shireen Mohammed, who generated some of the trauma data and the metabolic syndrome data. I want to mention Massimo Collino, who is a long-term collaborator, who is now a professor of pharmacology at the University of Turin. He, like Regina, did a postdoc with me a number of years ago. And also, of course, Regina, not only for inviting me today, but also for her friendship and acting now as a collaborator of mine for many years. So thank you, Regina, for this. So I'm happy to answer questions, but also if you have questions which you want to have addressed outside of this discussion, please email me at the email address which is pointed out to you on my slide. So thank you, and I'm looking forward to your questions. I think if you would like to ask the questions in Portuguese, you can do. I won't understand, but Regina can translate. But if they're difficult questions, I will answer them in German.
Good. Thank you very much, Chris, for your presentation. So we are open for questions. I don't know if We don't have any question yet, so I think I can start with one. So Chris, about the outcome from top art trial, I didn't know the outcome, so it was quite disappointed and curious, I think, to be interrupted because of thromboembolic events, as artesunate is known to have antiplatelet effects, right? I think.
What's going on?
Yes. Do you have any thoughts about why this happened or any explanation?
Yeah, I do have some thoughts. There are two elements in the data set which I was trying to highlight. One element was, so we have two different things. We have lack of efficacy on the one side, and then the thrombovascular effects. So lack of efficacy, I'm not 100% convinced that this is true, because the base excess was really high in the trauma hemorrhage group and much lower in the control group. So I think you would have expected the patients with artesunate to have much more multiple organ failure, and in the end they didn't. They had similar, let's say, and the intensive care stay was reduced. So the interims analysis said there was lack of evidence of efficacy. I'm not sure I agree with this. However, I do agree with the data on thrombovascular events. I think this was almost significant. And you have to, I mean, some people said maybe it's not real, but I think it is. You have to assume it's real unless you can really exclude it. Now, the only thing I've come across, we have in the past worked with erythropoietin. And erythropoietin, we have shown to work to also activate the AKT survival pathway, and erythropoietin is of benefits in patients with trauma in animals with trauma hemorrhage. So the data with erythropoietin were very similar with the artesunate data, and the mechanism was similar. Erythropoietin has been trialed in patients with trauma hemorrhage, and they found potential efficacy, but they found also a significant increase in thrombovascular events. Not quite as striking as we did. It was from 12% to 17% or thereabouts, but they had hundreds of patients, so it was based on a quite significant number. So the only thing I can find in common is the activation of the AKT survival pathway. So we have not done any further studies on platelet function, and I would wonder whether artesunate activates platelet function. You could argue that maybe trauma hemorrhage is different because you have already a baseline activation of platelet function, many other things. But in malaria, you will also have this. So I'm a little bit concerned about malaria, because when I spoke to the Bill and Melinda Gates Foundation, they said nothing happens in healthy volunteers. I agree. But in malaria, we probably won't have looked at this. In Africa and in Southeast Asia, they probably just looked at survivors. Nobody would look at thrombosis and platelet function. So I don't know whether this occurs in humans under other conditions. I think this needs to be certainly considered and investigated. I have no good answer, apart from the activation of the AKT survival pathway, no good answer for your question. I don't know, but I don't want to talk away this effect. I think it's real unless proven otherwise.
Okay, thank you. So we have two questions here. So first one is from Joyce. First, I congratulate you for your speech. In your opinion, what are the main causes of the failure of positive results in the process of translation from preclinical tests to clinical tests? What are we, basic research, going wrong?
I'm not sure I fully understand the question. What are the biggest problems in the translation? Is that the question?
Yes. What's the main cause of the failure of the translation? Yes. What we are doing wrong?
Okay. Well, what is easy to criticize and which is commonly done is to criticize the preclinical disease model. We often say, oh, these preclinical disease models are not translatable to the clinical setting. And this is often true for many diseases, because in general, we use very young animals, often male animals, and then we do the clinical trial in older patients, male and female, and they have comorbidities as well. So it's not the species. I don't think it's the mouse or the rat. I think it's the complexity of the disease in the patients, where they are much older and they have comorbidities, renal dysfunction, liver injury, and fatty liver, and they're overweight and diabetic, and so patients are much more complex. This is a good argument for many disease cases. It's more difficult, I think, for trauma hemorrhage work, because most of the patients are young and they're often male. So we use young and male rats. So for our trauma hemorrhage work, this is more difficult to explain. I think the biggest weakness of our trauma hemorrhage work is that we have an isolated blood loss. So we don't have any tissue trauma. I think it's a single species with just a hemorrhage and resuscitation, which is an ischemia reperfusion type injury. The other big problem in all preclinical studies is the timelines. We generally do experiments in a lab which take 24 hours in sepsis, or my colleagues do 24 hours in sepsis in a pig, but still 24 hours. In human sepsis, we look at 28-day mortality, because people die at the beginning, they die after 1 week, they die after 2 weeks, they die after 3 weeks. So it's a much longer process, I think. So I think this is, in my area, some of the challenges which I come across. However, if you turn the question the other way around, all the drugs which work in humans, which we have discovered, unless they're human specific, they also work in animals, right? All the antihypertensives works in animals, all the ACE inhibitors work in animals. So I think animals are still a right step to at least do what we have done and potentially discover some efficacy, some potential adverse effects, and some mechanistic work. This does not, as you have also shown, guarantee that you don't find any adverse effects in humans. For example, we didn't see any, we didn't look for platelet activation or thrombovascular events in our animals, but we didn't clearly, if the animals were full of blood clots, Regina would have realized. So I don't think we have that, but that we always have to keep in mind. Just because we don't see any adverse effects in animals doesn't mean that we don't see any in humans. So in the end, it will always require courage. In the end, it always does require courage to do the clinical trials.
Yes, and Joyce, she asked another question. She asked, how can we improve our studies to increase the chances of success?
That's a very good question, and a quite difficult one. I don't think there are any easy answers. I can give the answer and say, yes, it would be better to do male and female animals, which we're currently doing. In my lab, we have now started in sepsis to trying to find a sepsis model where we can use an equal number of male and female animals. This is not entirely easy, because often the inflammatory response in female animals is less, and so they behave differently. So if you have a moderate sepsis challenge and the injury in male is high and the injury in females is low, then you will never get anything significant because there's too much variation. So we use a very large septic challenge where the injury in both is very high and maybe a little bit less in females. And so we can use male and female animals. You can theoretically use older animals, but this is a cost issue, because if we buy animals which are 8 months old or 1 year old, they're difficult to get and they're very expensive. In the UK, they can cost up to £100 an animal. So then the rate limiting factor will become the animal model. The animal cost. One other thing one can do is what we're doing now quite a lot, it's called reverse translation. So instead of starting with a receptor antagonist for a specific receptor in a mouse and then going to a pig and then going to a diseased pig, you can start with the patient and taking a biopsy and make sure that the receptor is actually expressed in humans. It is related to disease severity. So you have some patient data and bring these patient data back to the animal world experiment. To some degree, we have tried to do this in our studies by looking at, for example, the antimicrobial peptides in humans, patients with trauma, and then taking it back to the preclinical model. So the more patient data we have, the better. So I think in the future, the information we gain from genetics, genomics, and bioinformatics in patients will be very helpful to guide the animal studies.
Okay. So Jamil asked you a question. Dear Chris, very nice to see you again. Very interesting data. Artesunate is effective against malaria, which itself produces coagulopathies. How this reconciles with the undesired effect in volunteers? Thank you.
I think this is a very good point. So, sorry, Jamil, I should clarify. In human volunteers, there are no undesired or thrombovascular events, but in our patients with trauma, there are. But your argument is correct. This is an argument I made earlier, that in malaria also there's activation of platelets, and there's also, thrombovascular events to a lesser degree, but there are. So if artesunate would increase the number of thrombovascular events in malaria, this would be very difficult to know because it's not investigated, unless it would kill lots of people, right? Because in the end, we just look at recovery. All the big clinical trials look just at mortality as the endpoint. So I don't think, the children in Africa or the children in Thailand would have any sort of assessment for thrombovascular events, unless there would be, lots of cases of death caused by, pulmonary embolism, for example. And Nick White, who is the malaria lead and was the person who did all the clinical trials on artesunate, was part of our clinical trials team. And he said, to his knowledge, this has not been investigated, but also there were no obvious, increases in mortality. In fact, the mortality was reduced. So I don't quite know how this tallies. I just don't want to take the easy route, Jamil, and say, maybe this is chance, maybe small n numbers chance, because, from 12 to almost 50%, I think it's awkward to argue that this is chance. But I agree with you, Jamil, and with Regina, that this is an area which deserves further investigation. And I must say, although others may want to pursue this artesunate into clinical trials with COVID, we had patents to use it in acute myocardial infarction and acute kidney injury, and we have not pursued this because I think you have to understand these adverse effects first, especially if the condition would be something like acute myocardial infarction, where you have a thrombovascular event. If you get more platelet activation, for example, I know it's on the arterial side, not on the venous side, but if you get more platelet activation, this would be a problem.
Okay. Thank you. And Chris, a curiosity of mine now, how long it took this trial since the idea of testing artesunating shock until the no happy ending of the trial? How long did it take?
Almost, I would say 10 years. The biggest delay, so I think I don't know all the dates, but I remember that we filed patents in 2010. So that means in 2010, long before you came to our lab, we had already some preclinical data of efficacy, and we filed these patents in 2009, 2010. So we had, let's say 2009, 2010, we had the first preliminary efficacy data and filed patents. And we had them also in myocardial infarction a bit later, and we extended the patents to myocardial infarction and acute kidney injury. Then I can't remember exactly when you joined my lab, but I think, the paper was published in 2017. So the preclinical data set was finished in 2017. And we had the first meetings with the MHRA and asked them for advice on the clinical trials in 2013. And one of the big questions was, do we really need a GMP formulation? Because if I have malaria, if I go on holiday in Africa, I come back, I have malaria, I get the artesunate from China. Nobody's worried about my health, that it's not GMP. So this will be given in any hospital in the UK, but it's not good enough to do a clinical trial. So this was the biggest delay to get the GMP formulation in Italy. The Italian colleagues said, yes, they have a GMP formulation and we can have it. But in reality, they were developing a GMP formulation. It took many years to complete. And now this is available. And actually, there's also an Australian company who manufactures a GMP formulation. So now GMP artesunate is available. But we, as I shown in the slides, we started the clinical trial then in 2017. The funding, these patients don't receive any additional care to normal care, but still we had to employ nurses, we had to employ clinical research assistants, fellows, do all the things which are necessary to do clinical trials. And this cost £1 million, but it was fully funded by the Wellcome Trust. The Wellcome Trust also funded all the clinical trials with artesunate malaria. So they were an interest. They felt that this if it's true and it reduces multiple organ failure, then this is a very cheap drug for trauma hemorrhage worldwide, right? Because it's a cheap drug. So this is why they invested £1 million in these clinical trials. But to come back to your question, around 10 years. This could have been quicker. I think big delay was the GMP formulation. So not every repurposing study will take 10 years. So I think if you have a pharma partner who has the GMP formulation and all the data, with artesunate, all the data were in a different place. Phase 1, US Army, GMP, you have to get this partnership off the ground. If you have a Pfizer drug, or let's say aspirin, you do repurpose aspirin, you work with Bayer, they have all the data, I think this can be much, much quicker.
Okay, thank you. Interesting. So another question from Professor Marco Red. Congratulations on your excellent talk, as always, Chris. What would be the best time to look for the patent in a successful preclinical study?
In any sort of patent application, this depends slightly where you live. And what I mean by this, because in the US, you can patent an idea. You don't have to have any data. In Europe, you have to have efficacy data. Now, how much efficacy data you need is relative. For example, when we do science, we want to have large N numbers, highly significant. I'm not sure that you need so much data. You need just some indication of significance. So in the extreme, if you did 3 animals as a control, 3 animals with one endpoint, let's say liver injury, AST, ALT, or 2 endpoints, you could file a patent on drug X reduces liver injury. Now, if you want in your claims to make the claim that it reduces multiple organ failure, then obviously you need more endpoints. You can make, based on whatever data you have, you can make in the claims, first you describe your data, like in a paper. And then in the claims section, it's a bit like the discussion of your paper. You can say whatever you like. You can say, I show it works against liver injury and sepsis. So I think it works against multiple organ failure and sepsis, and in trauma, and in COVID, and in liver disease, and in you can list whatever you like. But often what happens is that the people who then inspect these patents will challenge some of these claims, and say, okay, I believe you that it's working in trauma, but not in myocardial infarction, or not in scleroderma. You make wild claims there, and so you lose some of these claims. But the question was, when is it a good time? I think the good time is early, when you have the first data set. I should say, often in life, I started with John Wayne's serendipity and chance. Often in life, there's a lot of chance involved. In this artesunate patenting, there was a lot of chance involved. What happened was that our university tested, or wanted to test, a new search engine which could look at publications and patents at the same time. And nobody did test it. And then my boss told me, Chris, test the thing. You're working on this artesunate, test the system. So I did a search on this new system. I can't remember what it was called then. And it showed me that all the patents were related to infectious diseases and cancer. So there were lots of patents with artesunate in cancer and infectious diseases. Nothing in ischemia reperfusion, absolutely nothing. So because there was absolutely nothing on that side, I thought this is an opportunity, because we have, myocardial infarction, trauma hemorrhage, and so on. This is why we filed this patent. I didn't develop this project to have a patent, I must admit. So we only filed the patent because I saw this opportunity. One thing which I like to mention is that I would not have been able to get the clinical trials funding without patents, because the fund which was given to me, the money came from a grant application which said translational studies, and they wanted to see the patent history. They wanted to see the patents. So the Wellcome Trust wanted us to have patents in place. So I was lucky that we had these patents in place. But to come back to the original question, early, when you have the first efficacy data, you can always add to the patent and add claims to the whole story.
Okay, thank you, Chris. I think we don't have more questions and we are run out of time. So thank you again. Very nice talk, and really good to see you again. So hopefully the next talk will be here in Brazil.
Yeah, so hopefully the next meeting will be over a nice evening, nice dinner with you and Jamil and Marco. I hope to see you all soon.
Okay,
Thank you very much
you
for the kind invitation. Thank you.
Thank you. Thank you very much, and thank you all for coming to this.
Okay, thank you.
Bye-bye.
Bye-bye. I try to stop sharing.